Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome again to the INS Infusion Room. We have Dr. Van Doren back in the house for the third and final time for this very special three-part series where we have been discussing IV iron. Welcome back to the studio, Dr. Van Doren.
Thank you. I'm happy to be back and a little bit sad that this is the last of our three-part series.
Same. I'm a little sad by it too. There's great responses. We've had really great dialogue, and I'm really excited to hop into this next part where we're going to talk a little bit about hypophosphatemia and why it matters with IV iron infusions.
Yep, very important topic.
So, Dr. Van Doren, if anyone missed the last couple episodes or your webinar, can you give a little brief introduction to yourself and catch them up on who you are and where you're coming from?
Sure. So I'm Layla Van Doren. I'm an adult hematologist. I practice at Yale New Haven Hospital in New Haven, Connecticut. I am a classical hematologist through and through, and I focus specifically on iron deficiency and states that lead to iron deficiency.
Very versed and the perfect expert for the topic.
I guess so.
Okay, so diving in, what is hypophosphatemia? We'll start there.
Sure. So let me back up and just express why phosphorus is so important. It's a mineral that we have in our body, and it helps our muscles and really processes in our body function by generating ATP, which is energy.
Mhm.
And so that's why it's important.
Great. So, and we have too little of it, we have some issues, right? What are some of those
Exactly.
issues?
Yeah. So again, because it's used for energy, one of the things that can happen is muscle weakness. So just general muscle weakness, fatigue. It's necessary for cognitive function. So just slow thinking. And then obviously the muscle is a heart. And I think people forget that the muscle is a heart, right? So what
Yeah.
does our heart do? It pumps. And with low phosphorus, it can result in conduction abnormalities of the heart. So those are some of the reasons why it's so important. The other reason it's important is because it is necessary for bone health. So basically, we need phosphorus to survive. It's abundant in on Earth.
So, correlating that with IV iron infusions, we wanted to make this segment today because it's important to know the correlation and how IV iron infusions can contribute to this condition. So, let's talk a little bit about that. Give us an explanation of how they correlate.
So um, our body makes a hormone. It's called fibroblast growth factor 23, or for short, FGF23. And it's even higher, makes even more in people who have iron deficiency or inflammation. And basically, when it's released, this hormone, it's cleaved. Okay. And
You said it's cleaved,
it's cleaved. When it's released from the bone, it ends up being cleaved.
and what does
Okay.
that mean?
It's cut. It's
Cut.
basically,
Okay. Okay.
yeah, it's cut into an actin form. But the job is really to regulate serum phosphorus along with vitamin D and parathyroid hormone. But what happens, and this is specifically the theory with ferric carboxymaltose, which is what we see the highest degree of hypophosphatemia, the theory is that FCM prevents the cleavage of FGF23 so that there's an abundance of it floating around, which basically leads to phosphorus wasting through the kidney. And that's the theory of hypophosphatemia and how specifically ferric carboxymaltose leads to it. I will say hypophosphatemia can happen with any iron formulation, but by far, FCM causes the greatest amount of hypophosphatemia. We're not really sure why. It's probably something to do with the formulation, maybe the carbohydrate. I don't know that that's been elucidated yet. But Dr. Miles Wolff has actually published a lot on this topic.
Great. Wonderful. It's a great reference we can look into for those that are questioning what the difference really is and why there's one that's more significant than the rest. So, but that's really good to know, especially for nurses who are infusing this specific type of IV iron. They can look to see what additional consideration and looking for that hypophosphatemia. So, identifying hypophosphatemia, why is that so important? And do you have any case examples that you can talk through a little bit to connect the dots here?
I do have an example, and this is actually extremely important for nurses because remember, in the United States, ferric carboxymaltose is given as two separate injections, and the physician often does not see the patient prior to their next injection. Okay. The nurse will when they come back to the infusion center. So, what does that look like? Well, it's kind of tricky because the symptoms of hypophosphatemia can mirror those of iron deficiency. So, again, fatigue, cognitive dysfunction, muscle weakness. It can be profound, though, with hypophosphatemia, just not feeling right, numbness and tingling of the hands and the feet. And so, what a case will be, I'll give you a case. A patient of mine who had heavy menstrual bleeding, she received ferric carboxymaltose. She went back for her second dose a week later. I did not see her until 4 weeks
Or
after the second dose, where which is pretty standard, where she was feeling
yeah.
just awful and felt like she could barely stand. Well, in my mind, I'm thinking this is somebody who's received iron and her iron studies are normal. So this is not iron deficiency. She should be feeling like superwoman. So I checked her phosphorus. It was extremely low. It was less than 1.5. She was very symptomatic. And so just keeping that in mind, if somebody is still suffering from symptoms of iron deficiency, it's probably hypophosphatemia. And you should alert the physician to order a phosphorus level before proceeding with the second dose of ferric carboxymaltose.
Wonderful. Thank you for that case example. So, you mentioned 4 weeks. I imagine some patients can go longer than that, assuming that the IV iron infusions are eventually going to kick in, they're going to feel better. Why is it important to identify this and prescribe or treat
Sure.
quicker than later?
Yeah. So I will say the population that's at risk of hypophosphatemia are those who have normal kidney function. Because remember, this FGF23, it works on the kidneys, right? Those who require repeated doses of IV iron. So these are going to be people who bleed often. So your heavy menstrual bleeders, your patients with hereditary hemorrhagic telangiectasia, basically those who are requiring repeated doses. And so that's why it's so important to capture them and say, okay, they have hypophosphatemia. They should not receive further doses of ferric carboxymaltose. And in fact, some guidelines, such as the HHT guidelines, recommend against using FCM in those patients because of the frequency with which they require intravenous iron. It can be dangerous. So you remember when I was talking about the heart being a muscle
Yeah.
and phosphorus required for cardiac function. So this is why it's not just about weakness, it's about weakness of the heart as well.
You talk about changing into a different IV iron infusion. So, if you did have to change, maybe the first dose, couple doses were not successful, you need to have continued, but we have this issue. Is there a specific infusion that you would recommend switching?
So any one of them, you can take your pick. I mean, I actually have issues with with various formulations for various reasons. I prefer formulations where one could receive a total dose infusion. So usually 1,000 milligrams. There are um, So Infed you can give as a total dose safely. Ferraheme you can give it as dose safely. The only one that's FDA approved for 1,000 milligrams is ferric maltose. You probably know that. But any one of those would be acceptable. Obviously Venifer, but that's repeated doses, and so you could take your pick, but really it's just avoiding ferric carboxy maltose for repeated doses, or I just avoid it altogether in people who I know will require repeated doses of intravenous iron.
So, what is the best prevention for hypophosphatemia? Is there a way that we should identify this prior to IV iron infusion? Is that standard?
So the best prevention is really avoidance of ferric carboxy maltose. And because there really is no treatment for hypophosphatemia, it's really just time. Some people try to provide phosphorus, either intravenous, which is a very temporary fix, or oral phosphorus. But again, it's because of the phosphorus rate wasting. And so it's really just time. I would recommend to avoid it in people who are at risk of hypophosphatemia.
And though, just to recap, those patient types are, just to say it again.
Sure. So risk factors for hypophosphatemia would be normal kidney function, obviously iron deficiency, people who already have lower baseline serum phosphorus, and then those who will require repeat dosing of intravenous iron.
What kind of resources are available to clinicians to learn more about this specific consideration with IV iron?
Up until I would say even 5 years ago, I feel like there wasn't that much information out there on hypophosphatemia secondary to IV iron. But now there's an abundance and there's more coming out. And I think that's because the pathophysiology was elucidated. So again, Dr. Miles Wolfe, he's published on this abundantly. And so Wolfe, like WOLFE. So that's a resource that's available. And then certain guidelines, such as the HHT Cure Foundation, they have guidelines on hypophosphatemia. I published something with Michael Auerbach, guideline recommendations. I can't remember the exact name of the article, but if you look me up, you'll find it. And we have some recommendations on this topic as well.
Wonderful. Okay, so let's get into the recap. So we've had 3 awesome episodes about IV iron infusion.
Mm-hmm.
Let's think through that. What is the biggest advice or key information, talking about all 3 of these, that you could give a clinician in regards to the IV iron infusion?
I would say, okay, the first thing is, do not be alarmed if there's an infusion reaction. Okay. Do not be alarmed. I always tell the patient it's a possibility you may feel certain things here or there, and try to avoid assuming it's anaphylaxis and giving Benadryl and epinephrine, etc. That's the first thing. Second thing is, don't be afraid of intravenous iron either. Okay, that's probably should be number 1. But those are really the big takeaway points. And then just recognizing that hypophosphatemia is real and it's concerning when it does happen, but just being able to recognize it. Do you have any thoughts, anything that you took away, Derek, as the host?
That's great. I tell you what, I've learned all kinds of wonderful information from you. So I just want to say thank you so much. You're always so full of really big words and really detailed descriptions that really help individuals understand what the topic is you're discussing. I think we found that in the webinar, and then it held through all 3 of our episodes for this special series. So, I think you hit on the understanding the difference between CARPA and hypersensitivity. I think that was a really big one. I think our listeners are really going to have some really great takeaways from that. The dosing, I think, was important too, and how we run these medications and where. We've talked a little bit about where we could, and really the safety behind infusing IV iron infusion was some big takeaways. So understanding that it can be across different care settings and across the continuum and meeting our patients where they are is super important in today's day and time, and that we have to be open with patients' plan of care. With safety at the forefront, whether that's being monitoring, fusing within different settings, looking for reactions, and taking it a step further. Can it be something additional that the IV iron is actually causing, like hypophosphatemia? So just putting all
Yeah.
those together, I think, has been very beneficial and very influential in practice. And I think clinicians will gain a lot from this discussion.
I hope so.
Yeah. Well, it's been an absolute pleasure discussing all this information with you over the past, well, first off, the webinar and then now the podcast series. And we're very thankful for Pharmacosmos for sponsoring this special series. And with that, do you have any final words before you sign off for the last time?
If anybody has any questions or anything, just pass them along to me, Derek, and I'm happy to come back for more.
Wonderful. Well, thank you so much. And as always, thanks for joining us in the INS Infusion Room. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.